Welcome everyone. In today's video, we will discuss the neurological examination in a spine patient. We have already seen the local examination of spine. Now we will cover the neurological examination. So the neurological examination of spine is done under the headings of higher mental function, cranial nerves, motor system examination, sensory system examination, examination of autonomic system, cerebellar function, and meningeal signs. In this video, we will be focusing on the points which are more pertinent to the orthopedic spine examination, that is motor system, sensory system, and autonomic system. So let us start. We begin the neurological examination by commenting on the higher mental function. So we have to see whether the patient is oriented to time, place, and person. And you must also be aware of the Glasgow Coma scale, which may be asked. The next, we have to examine all the cranial nerves and comment whether they are intact or not. Now we come to the motor system. The examination of motor system is done under the headings of bulk, tone, power, reflexes, coordination of movements, and involuntary movements. So let us start with bulk. Bulk is assessed on inspection, palpation, and measurement. In inspection, you look at the size of the muscle and try to gauge whether there is any atrophy or hypertrophy. In palpation, you palpate the texture, consistency, and the elasticity of the muscle. Atrophied muscles are often soft and flabby. If there is wasting with fibrosis, the muscles may become hard and inelastic. Some examples are poliomyelitis and muscular dystrophy. We comment after this whether there is a atrophy or hypertrophy. There is also a condition called pseudohypertrophy, which is seen in Duchenne muscular dystrophy. This pseudohypertrophy occurs due to fibrosis of the muscle and fatty replacement, which gives the appearance of a hypertrophied muscle. However, it is actually fibrosed. The common location for this are calves, buttocks, and infraspinatus. After the palpation, we have to measure the bulk of the muscles. Now we are asked how to measure or where to measure. Now the answer is at the place of the maximum girth of the muscles. For a full-sized adult, some distances have been also described, which you must know. These are 4 inches above and below the olecranon for arm and forearm, 7 inches above the patella for thigh, and 4 inches below the tibial tuberosity for leg. Next, we have to examine the tone of the muscle. Tone is the state of tension or contraction found in healthy muscles. It is also defined as the resistance to passive stretch. So we have to move the limbs passively at various joints and see the resistance. Tone can be normal tone, increased tone, which is called hypertonia, or decreased tone, which is called hypotonia. Hypotonia is usually seen in lower motor neuron lesions, early stage of spinal shock, any lesion of the afferent sensory pathways like sensory neuropathy or tabes dorsalis, cerebellar disease, sleep, or drugs like hypnotics and anti-spasticity drugs. Hypertonia is an increase in tone. Now, the most commonly seen in the orthopedic spine practice is spasticity. In spasticity, it is a clasp knife type of spasticity, which is velocity dependence and is seen in upper motor neuron lesion. What is clasp knife? So, there is a initial resistance at the start of the range motion, which increases with applied stretch. So, we are trying to stretch the muscle, there is an increased resistance, and there is a sudden giveaway. So initial resistance with a sudden giveaway is clasp knife spasticity, and which is velocity dependent. That is, it is proportional to the speed of the applied stretch. So if you try to stretch it in a high speed, the initial resistance will be higher. The other types of hypertonia are rigidity. Rigidity can be cogwheel or lead pipe. In cogwheel, there are multiple catches and reliefs, like a cogwheel. So there will be an increased resistance, giveaway, increased resistance, giveaway. And in lead pipe, there is an increased resistance throughout the range of motion. Now, these are more commonly seen in extrapyramidal lesions like Parkinsonism. In dementia, there may be increased tone, which is increased in all passive movements, and this is known as Gegenhalten. And increased tone can be also seen in muscles across a painful joint. So if there is a painful joint, the tone around that joint may also be increased. However, this will be a very local increase rather than in both the sides or in both the upper limbs and lower limbs. But this has to be kept in mind. If there is a painful inflamed joint, the muscle tone around that joint specifically can be increased due to guarding. Now we come to muscle strength or power. So muscle strength or power can be quickly assessed by observing the patient how he is walking, standing up from sitting position or lying down position, dressing, undressing, and lightly jumping or hopping. Then we test the individual muscle groups of shoulder, elbow, wrist, the hand grip, and fingers. In lower limb, we go for hip, knee, ankle, and toes. Following the testing of the muscles, we have to know the grading of the power of muscles. It is done according to Medical Research Council or MRC scale. This we are anyway aware. So let us quickly revise. 0 is complete paralysis. 1 is a flicker of contraction. Grade 2 is power detectable when gravity is excluded or eliminated. So we do it in a plane in which the gravity is eliminated. Grade 3 is against gravity but not against examiner's resistance. Grade 4 is against resistance but there is some degree of weakness, and grade 5 is normal power. Now different nerve roots control different movements in the upper limb and lower limb. Some important nerve roots are shoulder abduction is C5, shoulder adduction is C6, C7, elbow flexion is C5, C6, elbow extension is C7, C8, both pronation and supination is C6, both wrist extension and wrist flexion is C6, C7, both finger flexion and extension is C7, C8, and both finger adduction and abduction is T1. In the lower limb, hip flexion is L2, L3 and hip extension is L4, L5. In lower limb, it is generally the opposite movements will have subsequent nerve roots. So L2, L3 here, L4, L5 here. Knee extension is L3, L4. Knee flexion is L5, S1. Ankle dorsiflexion is L4, L5 and plantar flexion is S1, S2. Inversion is L4 and eversion is L5, S1. Toe dorsiflexion or finger dorsiflexion is L4, L5 and finger plantar flexion is S1, S2. Now, though every movement is controlled by multiple nerve roots, each nerve root in the cervical spine and the lumbar spine has been assigned some key movement or muscle for the ease of determination of the spinal level. So, C5 has been assigned shoulder abduction, C5, C6 is elbow flexion, C6 is wrist extension, C7 is elbow extension, T8 is finger flexion, and T1 is finger abduction. Similarly, in the lumbar area, L2 is hip flexion, L3 is knee extension, L4 is ankle dorsiflexion, L5 is great toe extension, and S1 is ankle plantar flexion. We also have to know about the Beevor sign, which is used to assess the strength of the abdominal muscles. Now, here the patient is asked to sit up with hands behind the head with knee flexed, and we observe the umbilicus. If there is no weakness, umbilicus should stay in the center in its own place. If it moves up, it shows the weakness of the lower abdominal muscles, and so that the upper abdominal muscles are pulling it up. The lower abdominal muscles are T10 to L1. If it moves down, it shows a weakness of the upper abdominal muscles, which are supplied by T7 to T10. And if there is a movement to any of the side, it shows weakness of the muscles of the opposite side of the corresponding nerve roots. Next, we examine the reflexes. In reflexes, we have the deep tendon reflexes and the superficial reflexes. In the deep tendon reflexes, in the upper limb, we have the biceps jerk, triceps jerk, and the supinator jerk, which are very important. Now, these reflexes can be examined in sitting in supine position. There are different ways of examining the reflexes. The biceps jerk is assigned the nerve root C5 and it is controlled by the musculocutaneous nerve. Here, the forearm is supported and a finger is placed on the biceps tendon and we hit the hammer on the finger and we look at the contraction of the biceps muscle. Similarly, in triceps again, we hit on the triceps and we observe the contraction of the triceps muscle. A very important thing while demonstrating these reflexes is to look at the muscle that is supposed to contract. So while you are examining the biceps jerk, we have to look at the biceps and not at the hand, whether it is going into flexion or not. Similarly, we look at the triceps while examining the triceps reflex, not at the forearm, whether it is extending or not. The root value for triceps jerk is C6, C7 and it is supplied by the radial nerve. Supinator jerk, again, the forearm is kept in mid-prone position and is supported and you hit on the tendon of the brachioradialis and we look for a contraction of the brachioradialis with a flexion of the forearm. The root value is C5, C6 and the nerve is radial nerve. Now there is something called the inverted supinator jerk which is important. Here when we do the supinator reflex, instead of contraction of the brachioradialis and elbow flexion, there is finger flexion. Now for it to be called an inverted supinator jerk, both these things should be there. Finger flexion and absence of the brachioradialis contraction. So the finger flexion shows a upper motor neuron at C7. So the lesion is above C7. And the absence of brachioradialis contraction shows the lower motor neuron at 5 and 6. So when both of these are present, then it is a segmental sign and it shows a lesion at C5, C6 level. However, if only finger flexion is there and also there is a contraction of brachioradialis, then we just get the inference that it is an upper motor neuron at C7, that is the lesion is above C7 and it is not called an inverted supinator jerk. Only when it is accompanied by absence of the brachioradialis contraction, it becomes a segmental sign of lesion at C5, C6. In the lower limb, we have the knee jerk. The nerve root is L3, L4 supplied by the femoral nerve. Again, can be done with the patient sitting with the leg hanging or supine with the knee slightly flexed and supported. We have to hit at the patellar tendon. For ankle jerk, the nerve root is S1 and the nerve is medial popliteal nerve. It can be done in supine with the leg over the opposite leg or on the side of the couch with the knee flexed or sitting with the leg hanging. We have to dorsiflex the foot and then strike the hammer on the Achilles tendon and you look for the contraction of the gastrosoleus muscle. Now we have to know the grading of the deep tendon reflexes. So grade 0 is absent, grade 1 is present as in a normal ankle jerk. So grade 1 is normal for an ankle jerk. Grade 2 is brisk like in a normal knee jerk. So for a knee jerk, grade 2 is normal, grade 3 is very brisk and grade 4 is clonus. Now what is clonus? Clonus is a type of exaggerated deep tendon reflexes in which there is a repeated contraction of the muscle after a single stimulus. So suppose we are checking ankle clonus, we have to flex the hip and knee at around 90 degree and then we forcibly dorsiflex the ankle. There will be a contraction of gastrosoleus which will again relax and again contract and keep doing it repeatedly. Then this is called as ankle clonus. We can similarly check it for patella with knee extension. We can either push the patella down or push it up and there will be a repeated contraction of the quadriceps muscle if there is a clonus. Now look at the reinforcement maneuvers. Suppose we are not getting a reflex, then we have to do something known as the reinforcement maneuvers. What does this do? They increase the excitability of the anterior horn cells and increase the sensitivity of the muscle spindle primary sensory endings to stretch. So if we are not getting a reflex, we will do this maneuvers. The maneuvers in the upper limb are clenching the teeth or clenching the fist of the opposite hand. In the lower limb, it is the Gendrasix maneuver, in which patient is asked to interlock the fingers and pull against each other. Next we come to the superficial reflexes. The first superficial reflex is the abdominal reflex. Here the abdomen is divided into 4 quadrants by drawing a vertical and horizontal line along the umbilicus. Now the muscles on each quadrant is stimulated by stroking the skin over the muscle, either from outside to inside or from center to outward. Both are acceptable. Now normally there should be a contraction of that stimulated quadrant with shifting of umbilicus towards the quadrant. If there is a failure of this contraction, it is an abnormal abdominal reflex, and this signifies injury above the particular level. The upper quadrant muscles are T7 to T10 and the lower quadrant muscles are T10 to L1. The next reflex is the Babinski reflex. In Babinski reflex, the foot is stroked along the lateral margin up to the ball of the great toe. Now you can do it with an object like a key, blunt object like a key. The normal response, which is also called as the flexor response, is plantar flexion of the great toe and the other toes. Next extensor response is when there is a dorsiflexion of the great toe with fanning of the other toe. So dorsiflexion of the great toe with fanning of the other toes. You may also be asked the complete response. Complete response along with the dorsiflexion of the great toe and fanning of the other toes is dorsiflexion of the ankle and flexion at hip and knee. And an abnormal Babinski reflex signifies an upper motor neuron lesion. Now there are some alternates to Babinski described when there is a significant withdrawal reflex to plantar stimulation. When you stimulate the plantar aspect, some people will have withdrawal reflex. They will pull away the foot. If it is very significant, then you can do this alternative maneuvers. These are Gordon reflex, in which the same thing occurs with squeezing the calf. Oppenheim reflex, here you press along the medial border of the tibia, or the Chaddock reflex, where you scratch the skin over the lateral malleolus area, and the interpretation is same as Babinski reflex. The next superficial reflex is anal reflex. The root value is S2 to S4. Here the skin near the anus is stimulated, which may be a tactile stimuli or a slight nociceptive stimuli, and there is a contraction of the anal sphincter. This reflex is absent in lesions of chorda equina or conus medullaris. The next reflex is Bulbocavernosus reflex. Here again the nerve root is S2 to S4, and there is a anal sphincter contraction in response to squeezing the clitoris or the glans penis or tugging of an indwelling catheter. A T reflex, which has appeared following a spinal shock in a case of trauma, signifies the end of spinal shock. And again, this reflex is absent in early stages of spinal shock and in lesions of chorda equina or conus medullaris. The last important superficial reflex is the Cremasteric reflex. The nerve root value is L1, L2, and here you scratch the inner aspect of the upper thigh, and there is upper movement of the testis due to contraction of the cremasteric muscle. Here often the afferent and efferent limbs are asked. So the afferent limb is femoral branch of the genitofemoral nerve and ilioinguinal nerve, and the efferent limb is genital branch of genitofemoral nerve. This is again absent is upper motor neuron lesions above the level and lower motor neuron lesion at the level of L1, L2. Following this, we check for coordination of movements. Now, these are usually tests for cerebellum. Now, normally neurological examination, the coordination is described here. However, in some places, you may be asked to describe it after the autonomic system. So, depending on what is being taught in your institute, you have to present accordingly. In the upper limb, the important tests are finger to nose test. Here, the patient is asked to touch the finger of the examiner and his nose alternatively, first with eyes open and eyes closed. The second is dysdiadochokinesis. Here, patient is asked to do alternating, pronating and supinating movements over his palm with the other hand. And again, in a cerebellar problem, the patient will not be able to do it properly. In the lower limb, the test for cerebellum is the Heel-Shin test, where the patient is asked to move his heel of one foot over the shin of the other foot in a caudal direction. Again, a patient of cerebellar problems will not be generally able to do it. The last test is the Romberg sign. Now, Romberg sign is more a test for proprioception of the lower limb rather than a cerebellar function. So here the patient is asked to stand with the feet shoulder width apart, first with eyes open and with eyes closed. A patient with a problem of proprioception on the lower limb will fall once the eyes are closed because the visual cues are removed. In cerebellar problems, he may have problem standing with even eyes open. Another possible reason of Romberg sign positive may be labyrinthine problems, but the problem in labyrinthine problems is lesser compared to when you see in proprioceptive problems. And also in labyrinthine problems, patient may have positional nystagmus. Then we check for involuntary movements. Important are fasciculations. So we look at muscles for any fasciculations. These are visible, momentary and spontaneous contractions of muscles, and these are usually a sign of lower motor neuron lesions. We also look for any tremors, chorea, athetosis or any dystonia, which are more indicative of CNS pathology. Now let us come to the sensory examination. So in sensory examination, we have to acquaint ourselves with the sensory dermatomes. Now you have to see the pictures and try to remember it, but some of the common are lateral aspect of the arm is C5, lateral aspect of the forearm and the radial two fingers is C6, middle finger is C7, medial two fingers is C8, medial aspect of the forearm to just above the elbow is T1, above that is T2. Then you should remember level of the nipple is T4, level of the umbilicus is around T10. Groin area is L1, the pocket area is L2, knee is L3, medial aspect of the leg to the medial aspect of foot and the area of the medial malleolus is L4, lateral part of the leg and the dorsum of the foot, especially the first web space, is L5, and the lateral part of the foot, lateral border of the foot and the sole of the foot is S1. The buttock area is S3 and S4, S5 is just adjoining that area. Now the sensory modalities which are commonly checked are the sensations carried by spinothalamic tract, which are pain, temperature and crude touch, and the dorsal column sensation, which are fine touch, proprioception, vibration, 2-point discrimination, stereognosis and graphesthesia. Now these three are also known as cortical sensations because these require higher processing in the cerebral cortex, especially the parietal lobe, and other sensation should be intact for these to be tested. Pain can be superficial pain or deep pain. To test superficial pain, we use a sharp pin and the side of the tip should be used. A hypodermic needle is not used because it causes less pain and more piercing of the skin. And we test every sensation from abnormal to normal area. For deep pain, you squeeze the muscles of the forearm, calf, and tendon Achilles. Next is touch. For touch, we use a cotton ball or a wisp of cotton, and you can also sometimes use a tip of finger, but cotton is more recommended. And we again check from abnormal to normal in all the dermatomes. For crude touch, we can use a slightly blunted or rounded objects like the back of a knee hammer. And we look for any area of hyposthesia, anesthesia, or hyperesthesia. And generally, we mention the sensation as percentage of the sensation that is decreased compared to normal. Next is temperature. For temperature, we used test tubes with water filled in them with hot water of around 110 degree Fahrenheit and cold water of around 45 degree Fahrenheit of water is used. Next, we come to proprioception. Proprioception is again done for checking the joint position. Here we explain the procedure to the patient and we go from distal joint to the proximal joint. Now we have to stabilize the proximal joint with one hand and hold the distal part from the side. So it is very important to hold it from the side like this and not like this, because this may cause pressure to be transmitted, which may help the patient to tell the side to which it is moved. Now we explain what is up, what is down, and then we move the limb in different directions, sometimes up, sometimes down, sometimes 3 times up, 2 times down, something like that, not in an orderly manner, rather in a random fashion. And then if there are six correct responses at least, then we consider that proprioception is good. So we go from distal to proximal. If distal joint is okay, then we don't need to check the proximal joint. Next is vibration sense. Here a tuning fork of 128 Hz or 256 Hz is used. 128 is preferable because lower frequency will have higher vibration. First we put the tuning fork on the clavicle for patient to understand what is vibration, what we are saying, and then we check on the medial malleolus, tibial tuberosity, anterior superior iliac spine, radial styloid, olecranon, and the ribs. Last are the cortical sensations. The first is 2-point discrimination. Any blunt tipped prong like a divider can be placed, and we ask the patient to tell at what distance the patient can feel 2 points as separate points. So the normal 2-point discrimination points are different in different areas. For fingertips, it is around 2 millimeters. For stereognosis, we ask the patient to identify an object with eyes closed, and we should use familiar object. For graphesthesia, we ask the patient to close his eyes or her eyes, and we write letters on the numbers or some shapes on the skin with a blunt object, and the patient is asked to identify those numbers, letters on shapes. After the sensory system, we examine the autonomic system. Here we want to ascertain the bladder and bowel involvement. This is also done on points which are asked on the history. The signs that we look for are whether the patient is catheterized or not, whether there is any perianal anesthesia, whether the anal tone is normal, the anal wink and the Bulbocavernosus reflex, which we have already checked in the superficial reflex, and any increased bladder volume on abdominal palpation. Last are the meningeal signs, in which you check the neck stiffness, Kernick sign, and Babinski sign. So friends, in this video, we discussed the neurological examination of the spine. If you like these videos, please hit the like button and subscribe to the channel for further videos. Also comment in the comment section regarding the topics you will like to be covered in the future videos. Thank you.